The problematic bone stress fracture stroke reaction. It's important to remember that not all bone pain is necessarily a stress fracture, and actually they present in clinic far less often than you would think. A bone stress reaction is the precursor to a stress fracture in some cases. And essentially, if we don't address the issues that are causing the bone stress reaction, it can develop into a stress fracture. A bone stress reaction is that first onset of bony pain, and it can be quite a diffuse, large, painful area along the bone. And a stress fracture is where it's developed into an actual damage to the bone, so maybe a hairline fracture, a small crack in the bone. Essentially, they develop via a mismatch of tissue load and tissue tolerance. So what we might consider to be an overuse injury. So someone who perhaps has suddenly started doing HIIT training, or suddenly a runner who maybe has increased mileage too quickly, and the bone hasn't tolerated the load well enough, and so has started to break down. So the most common areas would be the tibia, the shin bone, the bigger of the shin bones, the calcaneus, so the heel bone, the medial malleoli, which is the inner ankle, as you would call it, and the metatarsals, the long bones of your feet. They're also not unheard of in the femur, so the thigh bone, and the pelvic area. As we've said, the most common people who would present with it would be runners, or perhaps someone who's doing a lot of HIIT training, so high intensity interval training, perhaps someone who's doing HIIT training at home, for example, on their concrete based living room floor instead of an exercise studio or a spring loaded gymnasium floor. And like I say, or perhaps a runner who's either new to running, or who has suddenly increased mileage beyond their tissue's capability. There's a lot of reasons why they would develop. There's intrinsic reasons, such as naturally your bone health, which can obviously vary from person to person, and males and females will vary, and a females, depending on their time of life, that will change, their overall bone health will change. Someone who's suffering with REDS, relative energy deficiency syndrome, would be more susceptible to a bony condition. Vitamin D levels, calcium, we kind of always tend to recommend that people ensure they're getting plenty of calcium in their diet and plenty of vitamin D, which is often a supplement. There are extrinsic factors as well, as we touched upon already. So training load and training type, have either of those things changed dramatically? Tissue capacity, how strong is that person? Are they able to tolerate the loads that they're asking their body and their bones to work under? Or has it simply just been a change in training? Have they gone from something more casual and low loading into something more explosive? It's something that we consider, stress fractures are something we consider to be clinical diagnosis, by which I mean they are often diagnosed in clinics such as this one. The need for scanning is very rarely needed. Actually, if a suspected fracture is x-rayed too soon, it often won't show. They might not show for weeks on a scan, so often you get a false negative, as it were, so no fracture is shown on the x-ray, but that doesn't mean that the fracture isn't there. Gold standard is an MRI, but they're particularly hard to come by. Clinically, the things we're looking for are, in our objective, are localized pain, sometimes swelling, not always, increased pain on activity, decreased pain with rest. Sometimes there's night pain, sometimes not. This is always after a thorough subjective, where again things like training load and training habit and diet and overall well-being are all noted. Diagnostic tools we use are fairly simplistic, but they're both specific and sensitive to bone changes. So simple hopping tests and vibration tests have very high specificity and sensitivity for these conditions. So they're the things that we rely on. But again, primarily it would be done in the subjective. Quite often people will tell us in their own words that it's a bony condition. We would also look to rule out a differential diagnosis. So in the lower leg, things like compartment syndrome or periocystitis, things that you might consider to be shin splints as an umbrella term. In the foot, things like metatarsalgia, neuromas, those kind of things we would want to rule out. And all over the body, tendinopathies would be in our thought process. And again, once we've ruled those out, we're kind of bottlenecking ourselves into a diagnosis of a bony change. So the police protocol is hugely important for bone conditions. Police is it kind of supersedes the RICE protocol, so rest, ice, compress, elevate. P being for protect. So sometimes people will be using boots or crutches, and they're not always needed, but they are immobilization tools. So we're protecting the bone. In some cases, rest is needed, particularly in the early days or weeks. So we're not putting undue load on the bone. But we know undue long rest can have negative effects, which is why optimal loading is important. And optimal loading, particularly for a lower limb bony injury, will include things like swimming pool walking or marching on the spot, jumping, landing, introducing a small step from jumping and landing, hopping, and then a run walk protocol to get them back up and running and getting that bone used to that new load. And it's important that we respect every step of that. And we keep gradedly or gradually loading the bone under new forces and new loads, so it learns to tolerate that and rebuilds and becomes a stronger bone afterwards. We then get into ice, compress, elevate, which are all things that we're all familiar with. Ultimately, I say to people with bone conditions, what we really want to focus on are those internal factors and those external factors. They're the things that are going to drive recovery and optimal recovery and long-lasting recovery. So how strong are you? Are your tissues strong enough now to tolerate the load we're asking it to take every time we run or every time we do our HIIT sessions? So how strong is the tissue? How long or short is the tissue? And so we need to focus much more on those things rather than external aids, which can offer short-term pain management, but actually aren't driving the recovery of the condition. So whistle-stop tour of bone injuries. If anyone's got any questions, please fire them away and I will get back to you.